everyone. Welcome to the Pearl In Fairview. My name is Rebecca Tindall. I'm the executive director here. If I haven't met any of you, welcome. Thank you for attending. If you have any questions after the event or you would like a tour, please see myself, Holly, or Renee there in the back. We are very excited to announce to have Dr. Joel Parker here with us this evening to speak on the topic of transitions, when to transition to assisted living, memory care, and hospice. So without further ado, Dr. Parker.
But they did get this in case anybody wanted to do like karaoke. After you.
Dr. Parker, we will need it for the Facebook
Okay.
for them to be able to hear us if you don't mind.
Absolutely. All right, so I know a lot of people in the room, but for those who don't know me, if I don't know you, I will meet you afterwards. But I'm Joel Parker. I am the medical director of Irish Medical Group. So we are an in-home primary care group. So we actually take the primary care clinic and actually go into patients' homes and serve their needs. So we started the group November 1st of 2022. So we're a little bit over a year and a half old now. Well received. We're able to reach a lot of patients in the community, and we're still growing, which is a good thing. So that is our go-to. So we'll talk a little bit about navigating life transitions, choosing between assisted living, memory care, doing some stuff about palliative care as well, and hospice. So I know we have a lot of people in here that are familiar with assisted living, familiar with palliative care as well as hospice care. So this is interactive. Please, chime in. Let's just educate everybody. Love it. So. So, introduction. So, again, we're going to talk about just kind of navigating the transition. And we all know this is tough for any type of so the biggest thing is it's challenging, right? It's challenging for the patients who may or may not know what's going on, they've been independent all their lives, and it just comes at a point in their life where they need some assistance, and it's hard to overcome that, particularly when you've just been independent all your life. So it's definitely challenging for the patient, but it's challenging for the family too, particularly when you talk about memory care, right, and prevention. Because now the family has to make a decision about what do I do with my loved one when I know they need some help. But do I want them to resent me for doing that? Do I want to release them into another environment? But we also have to keep in mind the safety of that patient and that loved one as well, right? So it's challenging. So, anytime a life transition, again, we refer to any kind of significant changes in the individual circumstance or health status that necessitates some sort of adjustment to their living arrangements, whether it's aging, declining health, cognitive impairment, terminal illness, and these transitions also require some sort of consideration to their physical being, their cognition, again, safety, right? Because a lot of these patients that are going on, how safe, right? They hurt themselves, they put themselves in harm's way. Speaking about personal situations, and I know we had a tough question to make regarding my grandpa when he was and unfortunately, he ended up hurting himself. And my mom couldn't forgive herself for that, right? So we just always have to keep that in mind. And also, the quality of life that was important. So, assisted living. What do these facilities provide? Housing is one, right? We're looking at some personal care services. And they also provide supplies and support for individuals who need assistance, right? But this is the big thing, some activities that they're living, but they do not require or do not give round the clock care, right? So if your loved one would need round the clock care, then assisted living may not be the correct facility for them. And when you think about this, about whether or not to decide assisted living versus staying at home, you kind of look for signs and difficulties with their ADL or activities they live in. So can they bathe themselves? Can they dress themselves? How do they do grooming themselves, right? Hygiene, managing their medication, that's a big one, right? A lot of times patients, I can't tell you how many times I go into a facility and they're in assisted living and we have medication and they're managing their own medication, but they're not managing it correctly, right? And then safety becomes a big problem, that's a big concern. And so we need, when we see that, we have to, have that tough conversation with the patient as well as family to say, hey, I'm not sure this is for everybody, right? And then when do we need to consider this? Again, safety, risk, and the current living environment. You're going to hear me say safety all the time. Safety is just really, really important. Availability of socialization opportunities, right? So I'm not a real big social person, but if I was a social person, when it came time to this, I would take a tour of the facilities, right? And I would see, interact with the residents, get a tour. I joke with my mom all the time. I tell her I would put her in a nursing home, but that's one. But I was joking. But assisted living is somewhere that I can see my mom like thriving, right? In the right one. Right, so we have to get the tour, look at the residents, see what kind of activities they offer to the residents, and it kind of goes from there. And then the different amenities tailored to the individual interests and preferences. My mom loves to get her hair done, so one of the first things I noticed about Pearl, that was a salon, right? So my mom would love that. She probably stayed there all the time, talking to everybody. Yeah. Memory care. You have great memory care is going to be on here, right? Just it's on this one, right? So, memory care opportunities, some communities that specialize in providing support services for individuals with memory impairment, and this comes from some of the ones that we know good at our community. Alzheimer's dementia, right? But it comes to the other form of memory care. People who suffer from strokes. Amnesia, the list for amnesia is gigantic, and that can cause some problems with memory as well. Again, cancer, tumors, seizures, particularly uncontrolled seizures, any type of traumatic brain injury, and any type of hospital brain injury. So, and prolonged CPR, and you come out of it, then you can have some hospital brain injuries that lead to some memory impairment. So when you consider memory care, look for signs of cognitive decline, memory loss, confusion, wandering type of behavior. You want to evaluate the level of supervision and specialized care that's needed to, again, ensure the individual safety. There is another assisted living facility, and I used to get calls on this particular patient all the time. They would just wander out, and they weren't in memory care, and so with that, just being assisted living, they didn't have a lot of trouble, and so this patient was just wandering out all the time. And again, when that occurs, safety is a big, big concern, right? You never want the patient to be injured unnecessarily. And you want to consider the importance of the structured environment, a tailored environment, better programming to support that kind of function that they need. So when should I get my memory tested? Hear this all the time. I don't really think it's a correct answer to this. Anytime you notice that there's some degree of memory loss, I think that you probably
struggle to complete tasks, memory challenges, any type of eligible or unexplained injury, forgetfulness. If they talk to you and you're asking the same questions 2 or 3 times during a conversation, you may want to kind of seek some professional evaluation. So how do we diagnose a memory disorder? So a lot of times a thorough history and physical exam. We do a MSE, which is a mini mental screening exam. I've had patients that have dementia, some mild dementia, mild memory cognition issues that they score high. So it's not that they don't feel. And also this is all about more formal, in-depth kind of neurotype evaluation that can include some neuroimaging, some lab tests. People don't realize, vitamin disruption, particularly DED, that can give you some issues with hormone imbalance and give you some disorders as well. And then this is the big one, the medication, right? So one medication can cause it. Every medication has side effects, including Tylenol, ibuprofen, right? So one medication can cause some memory disturbances, but when you have a patient that doesn't necessarily have a primary care doctor, they go to this urgent care, they go to this emergency department, they may go to this telehealth professional. And now, when you see it, now they have a list of 15 medications, and nobody's actually looked at it to see how all those medications interact with each other. So now you have polypharmacy plan of role that can give you some of the services. Balance of care. Am I going too fast? All right, good. So this is kind of like a holistic approach to healthcare. Again, I took the definition from the web, and this is kind of word for word that says holistic approach to healthcare that focuses on improving the quality of life for patients with serious illness. And I took a step back and like that's kind of what we all do, right? Look at it from a holistic approach for every patient. And they say it addresses the physical, emotional, social, and spiritual needs of patients and their families, so not just the patient itself or him or herself. And the goal is to actually provide relief from symptoms, pain, stress, regardless of the stage of illness or prognosis. And palliative care is kind of taking an evolution, right, all the way back from ancient civilizations where, delivering compassionate care for the sick and dying was really provided from one family members and then some religious figures in that community as well. A lot of times religious leaders were the community members in the modern era, actually the hospice movement, which was primarily John Oldham, James Thomas in the 1960s, kind of laid the foundation for palliative care. And then in 1990, the World Health Organization actually recognized palliative care as a true medical spectrum. So, I like to think of, well, I'll tell you that. Since then, palliative care has kind of evolved. All right, palliative care today. So now it's recognized as an integral part of comprehensive health care for patients with serious illnesses alongside curative treatments. It kind of serves as like a bridge between primary care and hospice for those patients that aren't necessarily ready for hospice. Palliative care kind of plays a role. And again, interact with guys. Provided in various settings, hospitals, outpatient clinics, nursing home, patient homes. They collaborate with different healthcare providers and actually provide support for patients and families. I kind of look at palliative care kind of when I was in med school. I guess, even when I did some rotations in medicine, the internists and the primary care doctors, they were still going to the hospital to actually be based in the clinic and actually go to the hospital informal answer is yes. And I think the formal answer is yes. I mean, we actually go to the patient's home, we take care of the patient, we take care of the family. We bridge that gap for those patients. We have that tough conversation with the patient as well as the family member. And then when they're ready to accept hospice, we become transition as well. I think palliative care has since gotten a reputation for strictly pain management, and I think that that's a bad reputation for them, because it's not just pain management. Correct me if I'm wrong, please. All right, four principles of palliative care: patient-centered, holistic, interdisciplinary, and it doesn't provide continuity, but this kind of places the patient and their preferences, values, and goals at the center of all care decisions. This should be paramount for anything we do, whether it's primary care, whether we're taking a patient around touring facilities, whether it's hospice care. We have to place the patient and their preferences and values at the center of everything, right? People throw around the term patient-centered all the time, but this has to be paramount. Addresses the physical, psych, social, and spiritual aspect of care, that involves team, and some continuity as well. All right, some goals: relieve the symptoms, obviously focusing on making the patient comfortable, and that entails pain management, but pain management is not the end all be all. Managing symptoms, whether it's pain, whether it's nausea, fatigue, shortness of breath, just making the patient comfortable, improve their overall comfort, which is obviously enhances their quality of life, and then you want to optimize their physical, emotional, and spiritual care. Promote dignity, autonomy, and well-being. This is kind of big because you want the patient to still have that dignity, right? They're going through a tough transition in life, and you have to always keep that in mind. Patient autonomy trumps everything, so we always have to keep that in mind as well. Support their decision making. Obviously, again, that autonomy, you want to involve your patient and the family in all their decision making. And this advanced care planning, I don't think we do that enough. I think we do it too late, in my opinion. I think we should do that in the very beginning, and just kind of get that out of the way, make the patient comfortable. I think the more they talk about it, the more comfortable they feel comfortable. Because anybody, I don't care who you are, you can be the toughest person, but death will come to everyone, right? And so there's a lot of fear, a lot of anxiety surrounding that. And so we just have to, the more we talk about it, the more comfortable the patient will be. All right, this is why I get nervous, because I got a lot of options. All right, so specialized form of care for individuals with terminal illness who have a prognosis of 6 months or less to live. I get preached this all the time. I feel like I'm a partner. I need to say that I have 6 months left to live. Okay. Get it. Focus on comfort, symptom management, emotional support, the patient and their families during the end-of-life journey. Some of the signs of advanced illness that you want to look out for, particularly when you're considering hospice care, is looking at their physical function, right? Are they declining? How quickly are they declining? And increased pain or symptom burden, and you want to make the patient comfortable at the transition. They're having to go back to the hospital all the time, and that is a big telltale sign. If their appetite is decreasing, if their brain is not telling them that their body needs nursing, that's another big sign as well. So you want to discuss those care preferences with the individual and their family. And always you want to consider the importance of dignity for the patient, respect for the patient, and actually giving them that holistic support of the conversation. And I'm going to pick on
I just like to mention that when we talk about palliative care, hospice, all hospice is palliative care, but not all palliative care is hospice. So you still get the fundamental factors that we discussed before with palliative care, with hospice care. And a lot of physicians get really nervous trying to certify a terminal illness, saying that someone has 6 months of life left. And I try to remind people that it's just a prediction. So it's saying if your disease continues along its path, that you could die in the next 6 months. We know from in the hospice world, we have people who live longer than 6 months, but people that aren't very hospice savvy tend to think that they're going to get kicked off after 6 months. So that's my opinion.
And for those who don't know, that is Dr. Bauer, the world-renowned Dr. Bauer. So when it's time to transition, again, some of the signs that indicate the need for transition, again, decline in physical or cognitive function that impairs their ADL, that's really big. If they have increased care needs that go beyond what we can manage, again, safely at home and support, right? You may have some are married, right? Eventually, your wife will get old. If it gets to a point where she always jokes that I'm going to be fine for her, but if there is a point where she's taking care of you, then I'm much bigger than her, right? So it is going to be hard for her to manage me safely at home. So we always have to keep that in consideration. Frequent hospitalization, again, prognosis, as Dr. Bauer said, 6 months or less to live, again, strictly a prediction. And knowing when it's time to transition to assisted living, memory care, palliative hospice, requires careful assessment of the individual's needs, preferences, and quality of life. We always have to involve the patient. And conclusion, navigating life transitions and choosing between any of the aforementioned can be extremely, extremely challenging, but it's essential to prioritize patient well-being, again, safety, and quality of life. And view this by understanding the available options that are available out there, assessing the needs and preferences of the patient and family, and then seeking guidance from any other healthcare professional that's working on it. And that will conclude my talk presentation. Any questions? Yes, sir.
Yes, sir. This is something I've wondered about for a long time, never asked the question, but it's a perfectly good opportunity to do that since you brought that up. Is there a hard line beyond that 6 months point that everything will be pulled back if the patient or the person?
So there are patients that graduate from hospice, meaning looking at them, I couldn't predict that they would have a prognosis of 6 months or less. But when we have the first 2 90-day periods for hospice and we reassess them afterward with a physical examination with our nurse practitioner or the physician every 60 days, the question that I have to write for Medicare, because I don't want to go to jail, is saying, yes, I could admit this patient today, and yes, I still would not be surprised if this person died 6 months from now. So it's risky, and some people feeling like I'm supposed to be a predictor, I'm gambling with this. But when we have documentation and an assessment that shows that even though this person has been on hospice for 8 months, we have seen a decline from day one, the start of care, to today. And as long as we can prove that in our narrative that goes to Medicare, they continue with us. I happen to have a patient that we assessed last week that is going to graduate from hospice. She essentially would be hospice appropriate for her dementia, but instead of having a trajectory of decline, she's having a plateau and a peak. We got her medications better managed, and she got to the appropriate memory care unit. She was in an assisted living, and she needed 24-hour care. Once the social worker and everyone worked with her family to get her to the proper setting, she flourished. And we want her to flourish. For people who think that hospice likes to hasten death, I'm like, we wouldn't make any money if we like to hasten death. I don't know, people say that to me every day. But we do have patients that when we assess them, if I look at them, we evaluate
and we're saying, I can't make that prediction. Those are the ones that graduate. But more times than not, we have patients that have that trajectory of decline that will keep them appropriate. Does that help?
And I will say too, to piggyback on Dr. Bowers, is that I think society and hospitals just got a bad rep in society as a whole because, and I'll talk about some of my colleagues here, as a primary care physician, we introduced hospice care, and we actually get hospice involved way too late for our patients. And so in society's mind, once hospice comes in, they're going to push a medication for my loved one, and they're not going to be it. And that's further from the truth. I think we, as physicians, nurse practitioners, physician assistants, we have to do a better job getting ahead of this and actually having that difficult conversation with our patients earlier on. And then we recognize that there is a decline, and from our best judgment, based on our assessment, they have 6 months prognosis when we have to start the law and hospice program. Any other questions?
I just want to say something. So my father-in-law and mother-in-law, I didn't mean to.
So my father-in-law and mother-in-law lived with us. My mother-in-law still with us, but my father-in-law had a rare disease, and he transitioned from home health communities, not Milton group, over to hospice. And he still had a state of mind where he was cognitively aware, and it was wonderful for us as a family because the nurse actually came in and sat with me, my husband, my mother-in-law, my father-in-law, and went over, okay, we're going to go over what hospice is and also all your end-of-life wishes. So they're together, we got to hear, and I was trying not to cry. Well, my father-in-law, he wanted to be, and we went over all that together. And then they could set up, they're like, we have funeral arrangements. And we did not, and so if you want to choose a funeral home, we'll have them come in, you can go ahead and set that up, have it all, we can set up the payments, figure out what you want. And so we did that. So it was a blessing to us because as he declined, we knew exactly what he wanted. We had the funeral arrangements in place, and also we had medications that we needed there to keep him comfortable. And by that time, as he lost his memory, he did have his regular caregivers from hospice that he adored. That now us brushing his teeth, he would bite my mother-in-law. He loved the cute little pretty nurse that our nursing assistant, and he would line up, and she would come to give him his bath and brush his teeth. And so it was a blessing to us because they could do those things that helped us that maybe we couldn't get done, and such a blessing, and it was a great transition, just the whole thing. If you do it correctly in enough time, and that was just a prime example of transitioning from home health to hospice, and it was a lovely way to do it. So,
Everybody deserves that, right?
Yes, that's right.
Any other questions?
So, and I apologize.
No.
To go back to, it's not that I haven't, I think, understood what you said so far. And this may be, I may be reaching for something that's maybe impossible. But that's the way I think. Yeah. Could one possibly go in and out of hospice, use that 6 months, and then actually have some sort of level of improvement, go back home, or not need hospice anymore, and then 3 months later they're back in the hospice again? I mean,
That happens.
does that mean there's no cutoff date on that, or you got 3 years and
It
you got
isn't.
more after hospice benefits?
No, it doesn't. So your hospice is Medicare Part A, so that is the Medicare that we use to have hospitalizations. And so when you revoke hospice or when you get discharged from hospice, it goes back to its normal Medicare Part A for patients that are over 65. That's a lot of, that is a time when I need Dr. Parker because I'll call him and I'll say, I have somebody who's graduating And then Dr. Parker just throws the ball right back when he calls me back and says, you know what, 3 months later, this person now looks like they're really declining, and then we'll accept the patient back.
It happens.
So there's no real dead end to it, because every situation is unique in and of itself.
That is exactly. Again, it's like the clarification that we make for Medicare. Of course, Medicare wants to prevent fraud in any kind of way, because we've seen people who will come on hospice for heart failure, and they'll be on iron medications to keep their heart pumping until they can get a heart transplant. And they get called and they get a heart transplant, and then they get off of hospice, and then either may or may not get the heart transplant, and they come back on and come off. So there's some people that may intentionally try to use it the wrong way, but that's rare.
And then just because you go on hospice or the patient goes on hospice, doesn't mean that me, as their primary doctor, has to stop seeing them. I can still continue to see them. And we prefer that as well, because we have developed that relationship, and we want to continue that relationship.
And I'm gonna wear you on that. This may be totally beyond the purview of what we're doing here. Is there any kind of medication things that you could talk about, like donepezil or not very things about diphenhydramine being inaccurate, something that can aggravate dementia, and just all sorts of things floating around out there. And
Every medication has a side effect, and so that's when you would need primary doctors to actually look at all of the medications, because just because one medication may have a side effect, it may have 10 different side effects when it interacts with this medicine over here. So it's difficult for me to answer purely on one answer like that. So, but that's why you have to look at it as a whole.
And Dr. Parker, we could mention like the Beers list, the Beers criteria. I mean, that's a list that's online of medications that have
years?
beers, like
I'm into
drinking
that.
a beer. Drinking a beer that has the list of medications that have, unwarranted side effects in the elderly, that we kind of use a guide. That's why we like say no to Benadryl for everybody, and I hear a patient takes Benadryl every night, and I'm just like,
Yeah,
I totally rock with that.
there are a lot of medications out there that will raise a red flag.
Well, I know that my wife and I both took Benadryl for a long, long time. It was a secret sleep aid. We took 50 milligrams instead of 25. And of course, that aggravated my prostate. I didn't know that was an issue until it was too late.
Sounds like you need a good doctor.
Huh?
Do you need a doctor?
But then after my wife was diagnosed with dementia, I found that was also could have a causal effect there as well. So you don't know. It's just, and then of course I've always heard that if you take 3 or more, it's of any kind of medication, it's Katie bar the door, and you have no idea what those interactions are going to be, depending on the specific person you're talking about. Because it could be just a barnyard list of things that you just can't predict.
Look at side effects can wrap around still.
You know?
Yeah.
But we want to try to diminish all of them we can
Yeah.
to limit those interactions.
I'm a big proponent of, first time I meet a patient, look at we call it medication reconciliation, look at all the medications. And I feel like they don't need to be on it, and it's not serving a purpose, then we can go on. Yeah.
I wonder, can I add that, and I said before, like if I have a patient that's homebound, I'll send them to Dr. Parker so Dr. Parker can come from them. Like it's totally okay if a person is on hospice and go to Cracker Barrel every Tuesday. Like some people think that they have to be like the home health requirements, that they're a homebound person. I mean, I've sent patients to rock concerts and to the beach and other places. So it's not exactly, we want people to enjoy their quality of life. But, they may not be in a state where they have enough energy to maybe have their family take them to Destin, but they don't have the energy to try to navigate Vanderbilt's parking garage and go to an office, and they need a different type of care.
Just wondering
great talk.
If you grab a brochure, we got a map in there to show you the variation.
Any questions?
Do you do, Sherry?
Yeah.
We have a situation where it's a terminal patient, and he's actually only 53 years old, and the wife is only 50, and they're moving here. So he's already on health care. Could you do a consult, I don't think you could, online?
Yeah.
To bring him here, because really as it is right now, we're actually, the hardest part of our job is putting them in the right place at the right time before it's too late.
Yep.
Exactly to all your points. And, this family is actually not waiting, but, they're asking all the right questions. How do we get with a doctor group, a medical group that can see him and assess him right away?
Things are coming from out of state.
Yeah, so.
We've done that before for patients that are moving into memory care or to assisted living. We would do the initial assessment by health visit, and then audio and video. And then when they actually come into town, we see them the same day they're here.
It's just interesting right now because we're actually having to call some of our communities to see if they would even take them. Because the situation is pretty unique, but we try to find the best place, obviously, at the right time versus waiting.
I ain't feel like somebody's gonna hit me in the back of the head. I like the haircut, by the way. Everybody's guilty of going online and finding out information that they should never read. And I may be guilty of that. But I have seen there are folks that say that there's 7 stages, and I know you could probably say there's 15 and still be right. But do you have any understanding or preference as to, or is it just patient-based in terms of I've got to see the patient and interview them before I can determine where they are? And
100%. It all boils down to the
so it's early, medium, and late.
Yeah, you have to do that thorough history and physical exam first. Sit down with the patient and the family, talk to them, and then kind of develop a plan for that.
Well, what levels do you prefer to use in terms of, is there a number, or is it early, medium, late?
As far as
Where they are in terms of their level of dementia?
oh, it all depends on with the assessment, right? Can you say that they have severe dementia, moderate dementia? I guess you can say that. But again, I put it under a broad umbrella and say dementia, and then kind of classify it. But I tailor all my treatment plans around my assessment for that patient.
Another question. Is there any point or benefit to having?
Let me give you one of my cards.
Wait a minute now, you're gonna not charge me for this. Is there any, so you made me forget my question. Is there any point in actually having one retested? Or I guess my real question is, there's what? Maybe there are 7 different types of dementia. Alzheimer's and all the others, and I can't bring them all. Is there any benefit of knowing what the actual definition or diagnosis is for any given individual? And will that in turn change the treatment plan? Or could?
It could, but I think we get hung up on the term dementia, and I think I personally like to look at it from a cognition standpoint, memory standpoint, and kind of what the patient is able to accomplish on a daily basis by themselves. And look at that as a totality versus hanging my hats on the diagnosis of dementia. I say theoretically because if the patient has vascular dementia, right, or they don't
before I ask my nephew.
We do. To Nashville? We do go to Nashville. Yes, ma'am. Mhm. All right. I appreciate everybody's time. Thank you.
Thank you. Now Rebecca's going to sing for us.
My gift to you will be that I will not sing. Every birthday we celebrate, but not with me singing. Again, my name is Rebecca Tidwell. I am honored to serve as the executive director here at the Pearl. If any of you I have not met, again, please see me afterwards. I'm happy to meet you. Wanted to tell you a little bit about the Pearl. Mr. Don Cunningham, his mother, needed a place to go. She did not want to stay at home anymore. She did need some assistance, but she didn't want to move in with family. We see that quite often. They don't want to necessarily move in with family, but they're not safe to be at home alone anymore. And so, being a builder, he said, I'm going to build a community that my mother would be honored to live in, and that I would be honored for her to live in. So, Don and Rosemary Cunningham, they built the Pearl here in Fairview, and I thank them for the opportunity to serve as the executive director. Renee is passing out a flyer that tells you a little bit about us and what sets us apart from other assisted livings. And the fact that they are local ownership and we have clinical leadership is one of the things that sets us apart. When you've got some numbers guy in the office and all they care about is the census line and the budget, you do not get the care that you will get here. I'm a registered nurse, have an MSN with emphasis on healthcare leadership and management. Been doing this for 25 years, so I've seen a lot of communities, facilities, whatever you want to call them. And I am proud to say that the Pearl is and will be different from any other community you've ever been in. Now, I was not involved in the building process, but he did put a lot of things into effect that I would have asked for anyway. The flooring that you see here is the same throughout the building. There are no thresholds for someone with dementia to trip over. How many of you have seen somebody take 45 minutes to step from carpet to linoleum because they don't know if it's going to be stable, if it's going to fall with them? We put a mini split in each room so that they can set their own temperature without worrying about what Mabel wants across the hall. We have a restaurant-style menu where they can order whatever they want, whenever they want, wherever they want. No military precision. We offer a Montessori approach where they can truly choose whatever they want for each and every aspect of their lives. We treat them as unique individuals. They're not a room number, they're not an age, they're not a diagnosis, a census line, a budget line. They're truly a unique individual. We have qualified, experienced staff. Holly has been doing this for 25 years. She's my right hand, Renee's my left. So there's nothing that we're going to ask our staff to do that we're not capable of and experienced at in doing ourselves. So just if there are any of you that have any questions for us, we'd be happy to answer them. And we do want to invite you to some of our other upcoming events. We do have a dementia caregiver support group. Thank you, Tiffany, for being here tonight, that we offer once a month. Dementia is one of those processes that the walk is not easy, and there's no reason for you to walk that road alone. So come and join a support team where they can assist you with tips and tricks to help you out on that road and just gather some support. We also try to have an educational event like this monthly. Carl Warden is an attorney. He'll be coming in May to speak about estate law, probate, estate planning, things like that. And then in May, we're having another craft fair. Many of you attended our one in October, and it was a huge success. The residents particularly enjoyed going out and shopping. So we'll be having another one of those May the 4th. Another thing that sets us apart is the fact that we age in place. Many of the assisted livings will kick you out to a nursing home as you decline. This is your home. You are here. Having the clinical staff and the
to know how to navigate those transitions and processes makes a huge difference. So, according to Tennessee state law, if you want a feeding tube or a ventilator, you do have to go to a nursing home. But as long as we can continue to meet your needs, we will try to do that right here. It's your home. We want you to be able to move in and stay here for the duration. Thank you again.
I have a question. I see that you say you don't allow feeding tubes, ventilators, or advanced wounds. If a patient develops an advanced wound, do they need to find where they're supposed to go?
If they are a hospice candidate, they can continue to stay.
Okay.
Yes. In Tennessee, an assisted living can host someone that has a stage 1 or a stage 2. Anything 3 or 4, hospice does need to be involved.
Okay.
And we are more than willing to partner with hospice to facilitate that so that they don't have to leave. Again, this is their home. We want people to be able to move in and stay. We don't want to kick them out. We don't want them to have to transition again because it is so difficult for them and their families.
Okay.
As long as hospice is involved.
Is that the same for feeding tubes, if hospice is involved?
Yes, as long as it is managed by a third party, is how the state puts it, then yes, it is okay.
Okay, thank you.
And IVs, short term, a 21-day,
Like an antibiotic?
a 21-day antibiotic, we just need some fluids, they are allowed, and then they do have to be recertified by a physician to say that another 21-day period is required, but it cannot be a long term.
Okay.
Do you have any age minimums?
No. So we have folks ranging from their 60s to their 90s. The state says that this average of all of the residents has to be under a certain age. So we are well within that, and we've had some folks that have, for various reasons, diagnoses that are not safe to be at home alone or have always lived with a loved one that are even in their 50s, and they are certainly more than welcome to be here as well. We do have 2-bedroom options. We are adding a memory care this fall, which will also have some 2-bedroom options. If you see a lot of our artwork is Nashville themed, so we'll have the Johnny and June suite in the memory care. We do have some married couples that live here now. Some share a room, some do not, based on